Dr. Mohanraj Muthukrishnan, you are here? Yeah. And is Dr. Somika Singh here? You will be after.
Good evening, everyone. I am going to present a case series. My title of my case series is Plethora of Lead Masses from Benign to Malignant. I have no financial disclosure and conflicts of interest. Introduction: eyelid tumors are the most common tumor lesions seen in the ophthalmology clinic. Chelation is the most common benign eyelid mass lesion. Among malignant lesions, basal cell carcinoma and sebaceous gland carcinoma are the most common worldwide and in the Asian subcontinent, respectively. Aim of this series is to report the clinical pathological profile and the surgical outcome of the patient with lead mass presenting to the tertiary eye care center. Methodology: in this case series, patient with lead mass presenting to the oculoplastic clinic in the tertiary hospital were recruited for a duration of 8 months. A detailed history, clinical, systemic and radiological examination was performed. Surgical excision with lead reconstruction was done, confirmed by histopathological examination. All cases are kept under follow-up. This is the first case. This is a benign like looking like mass. HB result came as a syringocystoadenoma papilliferum. It closed with a direct closure. This is the second case. It's a deep-seated mass, 46-year-old female. On examination, extraocular movement restricted in lateral gaze and choroidal folds seen. Excision biopsy was done. HB result came as a cavernous hemangioma. Post-operatively, extraocular movements are full and free and choroidal folds resolved. Case 3, this is a conjunctival dermoid cyst. In this case, to retrieve the mass, we used wire vectis for deep orbital masses. Mass removed without rupture. These are 3 cases of dermoid cyst. Deep orbital mass removed by wire vectis method. Okay. This is a case, the patient already outside went excisional biopsy suggestive of inflamed abdominal inclusion cyst. We did see MRI, it's suggestive of hemangioma, but we went for excisional biopsy with frozen section. The result came as a benign peripheral nerve sheath tumor. This is a case of abdominal inclusion cyst. The lid defect closed with direct closure with lateral cantholysis. This is also a recurrent case. The patient already went outside, went for excision mass. We went for excision biopsy with frozen section. The result came as papilloma. This next 2 cases are old age, presenting the malignant mass-like lesion. Incisional biopsy sent for both cases. It came as a sebaceous gland carcinoma, 4 mm wide lobe excision with frozen section, and lid defect closed with Cutler bead method. Result: there was 11 total 11 cases. 9 cases are benign, 2 cases are malignant. Those malignants are sebaceous gland carcinoma. Malignant cases are followed in medical oncology department also. There is no recurrence till the date. Discussion: eyelid tumors are the most common tumor lesions seen in the ophthalmology clinic, most of which is present in the 5th and 6th decade of life. HB examination for all the cases. CTMR indicated in case of post-septal examination, post-septal extension and bone involvement. PET and SPECT rule out the metastasis. Discussion: these are the various methods to treat the cases. We mostly went surgical excision with the standard frozen section. Conclusion: early detection and treatment improve the outcome and prevent complication. Multidisciplinary collaboration is key for complex cases like oncology department. Wire vectis also you can use the retrieve the deep orbital mass without rupture. For large masses, entropy incline we used to reduce the blood loss after giving incision. Eyelid reconstruction may be need for the large mass removal. Biopsy is agent for suspicious or atypical lesion. Malignant mass recurrence require long-term follow-up. Thank you.
Thank you, doctor. So I think it's a comment. A couple of your cases were clearly orbital lesions. They are not eyelid. So it might be a good idea to differentiate between the two because we are talking about eyelid lesions. And the second thing is, like in one of your cases, you showed that wire vectis can be used. But in orbital lesions, we have to be careful, especially the deeper orbital lesion, that there are adhesions. So we can't really put in wire vectis blindly without separating the adhesions. or else we might end up causing more damage.